and then let's get started.
Okay, I guess we're going to start. I will introduce our speaker. If you have questions, I'll keep an eye on the chat as we go along, and then at the end you can either use the chat or raise your hand or use one of the other React choices in Zoom, whatever seems appropriate. So Dr. Sarah Nowak is an associate professor at the University of Vermont Larner College of Medicine. Her research focuses on understanding and improving population-level health outcomes by examining the influence of healthcare systems on how patients and providers make decisions about preventive health behaviors. Her goal is to develop models and empirical evidence that can guide policies and interventions to enhance public health through improved decision-making around cancer screening, contraception, antimicrobial stewardship, and vaccination. And today, she is presenting on using VHCURES data to examine mammography screening trends. Take it away, Sarah.
Thanks. Yeah, thanks so much for having me. It's really exciting to be able to share the work that we've been doing on this supplement to the NNE-CTR grant. So I'm going to be talking about some work that we've been doing with the VCures all-payer claims data to look at mammography screening trends in Vermont. And we're going to be looking back at about the past decade and a half of screening in Vermont. So first, I want to provide a little bit of context about what's been happening related to breast cancer screening over that period of time, especially some of the guideline changes that have been influencing screening rates. And then I'll give a little bit of background about what the VCURES data is, what's in our all-payer claims data, and then I'll talk about the work that we've been doing to look at screening trends in Vermont. So kind of first, just setting the stage, why do screening guidelines change over time? And kind of the idea is that you get accumulated evidence over time about the relative benefits and harms for different groups, and different professional organizations might interpret evidence about relative benefits and harms, or probably more importantly, weigh evidence about benefits and harms of screening differently, which can lead to different screening guidelines for different age groups. So the primary benefits of screening that we're thinking about are early detection, leading to reduced morbidity and mortality from cancer. And then the harms of screening that we're thinking about are false positives, so having an abnormal screening mammogram that then leads to follow-on testing, which indicates that cancer is not present. Um, and then overdiagnosis, which is something that, unlike a false positive, with a false positive, you can identify that somebody experienced the false positive at an individual level. Overdiagnosis is something that you can only uh, sort of detect at a population level. And this is the idea that there are some cases of cancer that are detected and treated when you have screening that would never have become clinically apparent, never become symptomatic in a patient without screening. Some of my slides want to advance on their own. There's some kind of timing going on. So kind of over the past 2 decades, there's been this kind of patchwork and dynamic guideline space. And here I have, these are not all of the different organizations that issue breast cancer screening guidelines, but kind of three of the main ones that especially primary care providers are likely to be paying attention to. And so within, now it's not advancing. Okay, there we go. So within this time frame, our study is going to look at the time frame from 2010 to 2023, where there's kind of a lot of differences in screening guidelines across these three groups. So the top, the U.S. Preventive Services Task Force, the middle is the American Cancer Society, and the bottom, the American College of Obstetricians and Gynecologists. And I'll talk a little bit about the ACS and the ACOG guidelines and kind of their influence on things, but primarily we're going to be focused on the U.S. Preventive Services Task Force guidelines. These are the main guidelines that influence, for example, in the Affordable Care Act, these are the guidelines that determine whether preventive services should be covered without copay. Um, so the first kind of domino that led to a lot of these kind of guideline changes was the change to the U.S. Preventive Services Task Force guidelines in 2009. So prior to 2009, the U.S. Preventive Services Task Force recommended screening every 1 to 2 years for women ages 40 and up. And then in 2009, they changed their guidelines to recommend that routine screening start at age 50 rather than age 40, in the way that the U.S. Preventive Services Task Force grades recommendations. This kind of A and B recommendations are things that should be done sort of at a population level. A C recommendation is something that should be an individual decision based on kind of an individual's preferences or relative risk. And so they changed their recommendation around screening women in their 40s from a B recommendation to a C recommendation. And then for women ages 50 to 74, rather than recommending screening every 1 to 2 years, they recommended screening biennially every other year. And then for women 75 and older, changed their recommendations to say that there was insufficient evidence to make a recommendation about screening. And so kind of in the uh, immediately following this change, we had some evidence from different data sources, and I want to talk a little bit about the kind of data that have been used to try to understand mammography screening trends, and then how our all-payer data are different. But so this initial study that I'm showing is data from national commercial claims data. So these data only go up to age 64 because after age 65, most people are on Medicare rather than a commercial or other kind of insurance plan. Um, but this study was done in 2015 using data through 2012 and found kind of, if you look at annual screening, there's a small decrease in screening for women 50 to 64 and a decrease in screening of close to 10% for women in their 40s. So you'd sort of expect to see more of a decrease in annual screening because remember the guidelines changed from recommending screening every 1 to 2 years to recommending screening um, biennially. But then if we look at biennial screening, they saw kind of similar decreases in screening for both age groups. So about 6% decrease in screening for women 50 to 64 and about a 9% decrease for women 40 to 49. So again, U.S. Preventive Services Task Force is recommending basically against routine screening for women in their 40s, and we're seeing a very small decrease in screening, and we're seeing a decrease that's about two-thirds the size for women in that 50 to 64-year-old age group. And then this is kind of a similar look that was done in a study led by Dr. Brian Sprague, who is the lead on this supplement and also leads the Vermont Mammography Registry, where using data from the Vermont Mammography Registry, they were seeing a decrease of about 12% in biennial screening for women in their 40s, and then a smaller decrease for women ages 75 and older, and a decrease in screening for women 50 to 74, for whom biennial screening had been consistently recommended, a decrease of about 5%. And was there a question in the chat?
Nope, it was just Sheila saying, feel free to put questions in the chat.
Okay, sounds good. Um, and then in 2015, the American Cancer Society changed their guidelines. Um, and what they changed to was to no longer recommend routine screening for women 40 to 45 or 40 to 44, then to recommend annual screening for women 45 to 55, and then to recommend screening every 1 to 2 years for women 55 and older. So this was, again, kind of adding complexity to this breast cancer screening recommendation space. Um, so an important piece of understanding how breast cancer screening recommendations are going to impact patients is understanding what providers do. So this was a figure from a paper that some work that I was involved in where we did a national survey of primary care providers and asked both which guidelines they trusted more related to breast cancer screening, and then what they whether they were recommending screening for different age groups. Um, and so one of the interesting findings is that even for those providers who reported trusting the U.S. Preventive Services Task Force guidelines the most, they still a significant number of them, or a sizable number of them, were still recommending routine screening for women in their 40s and to women 75 and older. Um, they were recommending screening at much lower rates, significantly lower rates than providers who reported trusting the ACS or the ACOG guidelines. But as you can see, for women in their 40s, still over half of providers were still recommending routine screening. Um, and then for those who reported following the American Cancer uh, Society guidelines, they were somewhat less likely to report recommending screening for women 40 to 44 than they were to recommend screening 45 to 49. Um, but you still saw very high rates of those providers recommending routine screening for women 40 to 44. And then, so now this is some work that I did with Dr. Brian Sprague and Dr. Andrew Wilcox, who's was at UVM at the time, looking at trends in mammography screening using data from the BRFIS, the Behavioral Risk Factor Surveillance System. So, of course, this is self-report data about people's preventive behaviors, including cancer screening. And so, once again, what we are seeing is somewhat of a decline in screening within the past 2 years for women in the 40 to 49-year-old age group, somewhat of a decline for women in the 75 and older age group, but also what looked like a small decline for women in this 50 to 74-year-old age group where biennial screening has been consistently recommended. And kind of beyond that, what we decided to do was to look at state level changes in screening rates from 2010 to 2018 and look at the relationship between whether we saw a decrease in screening for women in their 40s and for women in that 50 to 74-year-old age group where screening is consistently recommended. And what we found was a correlation. And beyond that, Vermont was kind of at an extreme of having a larger than most states in terms of both the decline in screening for women in their 40s and what appeared to be a related decrease in screening for women 50 to 74. And then we looked at whether there was a similar relationship for the decline in screening from 2010 to 2018 for women over 75 and older, again correlated with the change in screening for women 50 to 74. And again, Vermont appears to be kind of on the extreme end of larger decrease in screening in both age groups compared to most other states. And then, of course, in addition to all of these guideline changes that have been happening over this time period, we also see that COVID happened in 2020, which led to uh, a temporary dip in screening rates. So this is, again, a study led by Dr. Brian Sprague that used data from the Vermont Mammography Registry to look at screening rates, which found a decline in screening, especially looking at annual mammograms versus biennial mammograms in 2020. Um, so that's kind of the context that for the period that we're going to be looking at, the past decade and a half. Um, our data doesn't continue into 2024, but important context to think about is that in 2024, the U.S. Preventive Services Task Force once again updated their breast cancer screening guidelines, now once again recommending routine screening for women starting at age 40 instead of age 50. And so there are kind of good reasons for a lot of these changes because there's, as technology changes and different screening modalities become available, the relative benefit, the both the balance of harms and benefits can change for different age groups. So in particular, I believe that it's breast tomosynthesis that was found to have lower rates of false positives for women in their 40s, where previous screening methods had higher rates for women, rates of false positives for women in their 40s. And so that's kind of what led to the switch. But I think it can lead to a bit of confusion and uncertainty about kind of screening, which is the context that we're going to see when we look at the trends over the past decade and a half in Vermont. So maybe I'll just pause there for a second and see if there are any questions about that background before I dive into some of the data that we're using. Okay. Um, all right, so the study that we did was using data from the Vermont Healthcare Uniform Reporting and Evaluation System, or VCURES. And so you might have noticed that all of the previous studies looking at breast cancer screening trends that I talked about came from these different kinds of sources. So in some cases, you had claims from a single payer. So if you have data from a single payer, then you can't capture transitions across payers. And you can't, especially, it's difficult to bridge the gap between 64 and 65. So if you're using data from a commercial payer, like what I showed, you're going to be looking at the 64 and under population. A lot of studies are often done with Medicare claims that capture the 65 and older population. But claims from a single payer, it's difficult to capture transitions across this age group or age boundary. And then I presented some trends from the Behavioral Risk Factor Surveillance System, or BRFIS. That is a cross-sectional survey, so you're able to look at trends over time, but you can't look at changes in individuals over time. And it's also self-report data. And then also data from the Vermont Mammography Registry. In this case, there are other mammography registries that are part of this larger breast cancer screening consortium. That data can be great in a lot of ways because you can capture individuals in a way that doesn't depend on their payer. You also will get data from people who are uninsured. You do have longitudinal data, but the challenge with that data is that you can only observe people who have been screened. So if you have data for a woman who's been routinely getting screened and then she doesn't appear on the data at some point, you don't know if that's because she left the area that's captured by the mammography registry or if she in fact would have been captured if she had been screened and just hadn't been screened. So some of these limitations can be addressed by all payer claims data. So importantly, the all payer claims data um, captures claims from most payers. So you get Medicare, Medicaid, and then most commercial payers. There are also IDs that are created in the data that enable you to follow individuals over time, even across insurance transitions. And so what's really interesting in these data is the ability to follow individuals across that transition from 64 to 65 when people transition onto Medicare. Um, and then in addition, we have the medical claims, but we also have enrollment data that tell us what the total population of people reporting um, to the data are. So um, even if somebody doesn't use any medical care whatsoever in a particular year, you would be able to see that that ID is whether or not they're in the enrollment data. So you know, is this person outside of the universe of the data set, or are we capturing everything that happened and just they didn't get any care or any screening in a particular year? Um, Some of the other uh, limitations of the data is that we know that a test was done, but we don't know the results of that test. And so that's why part of this overall project and overall supplement, not that I'm going to be talking about today, but other work that we're doing involves linking the VCURES data with the Vermont Mammography Registry data because the Mammography Registry data tells us the outcomes of the imaging tests, while the claims data does not. So getting those linked creates a much more powerful set of data to understand what's going on with breast cancer screening in the state. And then a big limitation of the data is that from 2016 going forward, there was a Supreme Court case that restricted the ability of states to require large self-insured employers to report to these data systems. So there are some large self-insured employers that voluntarily contribute to the VCURES, but they can't be required by the state to contribute data to VCURES. And then, of course, we're missing uninsured or self-pay individuals, any self-pay care. Um, so, like I mentioned, overall, this supplement is kind of there are two main prongs of analysis that we're doing, the mammography trends analysis that I'm going to be talking about today. And then there's work with this linked data between the VCURES data and the Vermont Mammography Registry. And a lot of what we're doing right now is trying to understand kind of what fraction of breast imaging captured in each data set is also uh, observable in the other data set, and then also basically trying to validate different ways of identifying screen indication. Because in the Vermont Mammography Registry, we know whether screening was done or whether imaging was done for screening or diagnostic purposes, and we can use that to validate ways of trying to determine that with the claims data alone. Um, And so this work is primarily being done with Dr. Brian Sprague, Jonathan Emery, and Dr. Erica Zeller. So now I'll talk about the trends work that we've been doing. So the main research questions that we had were, um, we know that screening has been declining over time, and it looks like it's happening across age groups, not only age groups that were impacted by guideline changes, but even for that 50 to 74-year-old age group where screening was continuously recommended. Um, so a question is whether this is driven by just a cohort effect where younger women who are sort of um, reaching screening age in an era where screening wasn't recommended for them in their 40s, is it just that population that's driving the declines in screening, or is it broader than that? And then we can also do some analysis to try to understand what individual level predictors of mammography screening are. So we did our analysis looking at two sort of subsets of the population. So our first cohort, we defined an overall population of women who were at least 40 years old between 2010 and 2023. So 40 years um, at any point in that time frame. They didn't have to be 40 before 2010. Um, And in this population, we wanted to restrict it to individuals who are enrolled in an insurance plan reporting to VCURES for all 12 months in a given year. So they'd be included in the cohort in any years that that was true, that they had data for all 12 months of the given year. Then we also defined a continuously enrolled population. So this population included individuals in the overall population, and then additionally, people who were enrolled in a plan reporting to VCURES for that entire time period from 2010 to 2023, or they were enrolled in a plan reporting to VCURES every year once they turned 40. So we allowed people to enter the cohort if they weren't 40 in 2010. So this is the table of our study population characteristics. So first of all, we were able to identify 244,000 women in the full cohort, and then roughly a third of those were also in the continuously enrolled cohort. So we have a fairly sizable population that we have close either 14 years of continuous data for, or at least data for every year since they turned 40 in that cohort. The mean age was similar in the two cohorts, but we have a lot fewer individuals ages 75 and older in the continuously enrolled cohort. And this is just because we wanted to restrict the cohorts to individuals that we could follow through the entire study period. And of course, somebody at the very lowest age of, and sorry, this is the age that they were at the entry of the cohort. So of course, anybody who was 75 in 2010 was 90 or nearly 90 at the end of the study period. And so we don't have as many people qualifying for the continuously enrolled cohort in that older age group. Um, and then in our continuously enrolled cohort, so our total study period is 14 years. So most of the people in that cohort are going to be in the data for the entire 14-year period. But then the mean span of years that people are in the data is going to be a little bit lower than that because we have those women who enter the cohort when they turn 40 after 2010. In our full cohort, the mean span of years that we have data for is almost 9 years. Um, and if those years weren't for most women, we have data for that entire time period. So the average number of missing years was half a year. So it was a lot more common for women to, enter the data, be in the data for a number of years, and then exit the data and not necessarily come in and out of the data. And then in terms of insurance, the kind of Medicare and Medicaid rates looked fairly similar. Unsurprisingly, our continuously enrolled cohort is just going to be a little bit better connected to insurance and connected to care than the full cohort. Um, and related to that, we have a somewhat lower rate of Medicaid in the continuously enrolled cohort compared to the full cohort. Um, so, of course, individuals on Medicaid are more likely to see transitions between different types of insurance that could, for example, put them on a plan for a period of time that doesn't report data to VCURES, or to lose insurance for a period of time, which would disqualify them from being included in the continuously enrolled cohort. And then similar to that, if we look at the whether people had primary care visit in the first year of being in the cohort, we saw a higher rate of primary care visits in that continuously enrolled cohort that's going to be better connected to care compared to the full study population. And then the rates of virality were fairly similar in the full cohort and the continuously enrolled cohort. Um, so the main outcome of interest that we had was looking at biennial mammography screening. So with the claims data, we could use current procedure terminology or CPT codes to identify screening mammograms. And we considered somebody adherent to biennial mammography screening in a given year if they were screened either in that year or the prior calendar year. And then the age groups that we wanted to break down all our results by and look at were the 40 to 49-year-old age group that experienced this uh, transition in whether they were eligible for routine screening under the U.S. Preventive Services Task Force guidelines, the 50 to 74-year-old age group that for whom routine screening was recommended for this entire time period, and then the 75 and older age group, which after 2009 fell into that insufficient evidence category for routine screening. So the first thing that we wanted to do was to look at how different our continuously enrolled cohort screening trends were compared to the overall population screening trends. And what we saw was that, unsurprisingly, the continuously enrolled cohort had somewhat higher screening rates compared to the entire cohort, but for the 40 to 49-year-old age group, the trends were very parallel. The circled years are the COVID years. You can see the decline and then increase after COVID. So again, we're seeing a decline in screening for the 40 to 49-year-old age group, regardless of which cohort we look at. Similar with this 50 to 74-year-old age group, we're seeing somewhat of a decline in screening in both age groups or both cohorts, relatively parallel trends, dips around COVID with rebounds. And then for our 75 and older age group, we do see somewhat different trends in the continuously enrolled age group compared to everybody. And this is because it's kind of an artifact of the way that we set it up for the subsequent analysis that we wanted to do, where we were restricting the continuously enrolled age group to women who, where we had data for that entire 15-year period. So the 75 and older continuously enrolled age group is going to be a lot younger at the beginning of our time frame than at the end of the study time frame, because in order to be eligible to be included, they have to survive that entire time frame. So you're going to get a lot more 75-year-olds in the 75 and older age group in 2010 compared to 90-year-olds in this age group in 2010. But we were happy with the fact that for the other age groups, we're seeing fairly parallel trends. So we think that it's valid, there's validity in looking at trends among our continuously enrolled age group when we want to look at cohorts. So this was the next thing that we did, was to look at trends in mammography screening by 5-year age group cohorts. So each line on this figure is the group of the same set of women who are in our continuously enrolled cohort for the entire 14-year time period, or in that cohort for the entire period since they turn age 40. So are the mean age of the cohort is our horizontal axis. The percent who have biennial screening is our y-axis, and then the years we have in these different colors, going from dark purple in 2010 to yellow in 2023. So kind of the first thing to notice is that at any given year, women at older age groups up until age 70 are more likely to get screened. But within any single cohort, we're seeing declines in screening over time, at least until the circled pandemic years. And in some cases, we're seeing rebounds after those declines that exceed what the pre-pandemic screening rates were. And that rebound is especially robust for the younger age groups. Um, and then we're also seeing that at any given age, for the most part, the younger cohorts are less likely to be screened at the same age than older cohorts were in the past when they were the same age. Maybe I'll just pause here because this is kind of a complex figure to see if there are any questions on this. Um, so then the next thing that we wanted to do was to use fixed effects logistic regression to look at individual level predictors of mammography screening. And for this, we were able to use the entire cohort. So just kind of a quick either refresher or if you haven't seen this before, individual fixed effect models. The idea is that you want to look at for example, if you have a hypothetical outcome on a continuous scale here on the y-axis, we're giving every individual their own intercept. And so what that allows us to do is to understand what trends look like within individuals. So with this hypothetical example, have not unlike our screening example, you might have a case where for any individual, as they age, the outcome decreases. But then if you look across the entire population, the outcome could be positively correlated with age. And so this individual fixed effect model allows us to look at the left-hand case because we have separate intercepts for every individual. And then the other concept that I just want to kind of introduce before showing you the results is we decided that we wanted to model the age trends with a piecewise linear model. So with the piecewise linear model, for within the 40 to 49 age band, 50 to 74, and then 75 and older, each of those segments gets its own slope, and then we allow discontinuous jumps between the segments. So I'll show some results for both the slopes within the age bands and then also the jumps between the age bands. All right, so these are the results from a logistic regression predicting mammography screening with that within individual model. So what we see is basically no change in an individual's likelihood of getting screened in the 40 to 49-year-old age group. A negative slope, so a consistent per year um, odds ratio of 0.9 each year from 50 to 74, and then an even sharper per year decline in screening with a year-over-year odds ratio of 0.5 in the 75 and older age group. Um, but we also see a jump in the likelihood of getting screened when individuals enter that 50 to 74 age group. And then maybe a small jump, but not really statistically significant when people first enter the 75 and older age group. Within individuals, we see a big decrease in the likelihood of being screened when women go on Medicaid, and a slight increase in the likelihood of being screened when individuals get onto Medicare. So remember, in that 50 to 74-year-old time frame, year over year, there's a decrease in screening, but the transition to Medicare is associated with a slight increase in the likelihood of being screened. The pandemic years, so 2020 and 2021, are associated with a decrease in the odds of being screened, so a 0.9 odds ratio. And I think this was one of the most interesting results to me, I think, is that those post-pandemic years are associated with a pretty big increased odds of being screened. And so it's important to remember that this is in the context of basically in every age window that somebody is in, they have a year over year decreased likelihood of being screened. And so this is kind of, if you're going to follow that trend down, the post-pandemic years do provide this sizable boost relative to the trend that you would expect in the absence of defining these kind of separate time periods. Interestingly, we have a somewhat higher odds of being screened for our rural populations. And then we see a significantly, substantially higher odds of being screened when somebody has primary care in a given year. Um, so I think it's been really interesting to see how there was a decline in screening for women 50 to 74, um, even when screening guidelines didn't really change for women 50 to 74, other than just a change from recommending screening every year to 2 years to biennially. So it kind of seems like the messaging starting in 2009 with those initial changes to the U.S. Preventive Services Task Force guidelines might have led to some spillover, making women in all age groups less likely to be screened. And it kind of suggests that there might be a need for really careful messaging around those latest 2024 guidelines that once again recommend routine screening for women starting back at age 40 instead of starting at age 50. Um, It's interesting that COVID appears to have provided this opportunity for women to get reconnected to care, where we're seeing not just people resuming kind of pre-pandemic levels of um, mammograms, but it seems like that rebound really exceeded what we would have expected that would have been if it had just been a return to normal. I think a question that we still have that would be interesting to try to dig into more is whether the primary care provider effects that we see are causal or whether they're kind of related to other factors that might either lower barriers to care or something like that that um, is impacting a woman's likelihood to see a primary care provider and get a mammogram in the same year, kind of at the same time. And then also, virality is associated to higher rates of screening, which kind of differs from a lot of what we see in the national context, which is interesting. And what I understand, it's possible that it could be related to some wait times associated with kind of Chittenden County in our state. And then I want to acknowledge the rest of the team that worked on this. Oops. And of course, this grant and supplement from the NNE-CTR, which allowed us to do this work. So thank you very much, and I'm happy to take any questions or thoughts.
Thanks, Sarah. Any questions from people? Why do you think Vermont had the was an outlier on those graphs where we were looking at the percent decrease?
It's a really good question. It seems like I mean, I kind of feel like there might be something where people are more, primary care providers are more willing to accept the messaging to do less and to be more
Hmm.
willing to think in terms of those benefits, harms calculation, but I'm not really sure.
Ben might have an opinion on it.
Ben might have an opinion.
Oh, I have why were the outlier there? I don't know.
Oh, okay. You have a
Um,
different question.
well, I will say primary care has been shown to increase screening in umpteen other settings. Um, there may be covariates, but it's probably causal. I don't think that's such an interesting corner to go into. I am
I guess
interested.
it was so big, I guess was what was surprising to me.
Yeah, it always is. It's massive. If you
Yeah.
must if you must get health care, make it primary care. Um, the what about linking the two data sets, the claims and the mammograms?
So that was done by OnPoint, which is the contractor who that puts together the all payer claims data. So they get the claims from all the different payers. Um, and they have their own sort of hashing algorithm where so we get de-identified data from VCures. They have the identified data from VCures. Um, they were given identified data from the Vermont Mammography Registry and did the matching that way and then gave us back kind of basically just the crosswalk of IDs.
Can you now look at the medical utilization of women who do and do not return for scheduled mammograms or for post mammogram follow, biopsies and the lost women is what I'm thinking. Can we characterize the lost women and
Yeah,
try and find out are there predictors? Are there intervenable variables here?
yeah,
Because increasing the screening rates when the positives aren't getting worked up is a nightmare.
yeah, yeah. Yeah, I think that's definitely an avenue that would be great to go down with this link data.
Let me know.
Gene? Jan?
Yes, that's Jeannie or Jean. Um,
Sounds good.
I two things. On the issue of the missing women, one thing that I think is hard about characterizing those people is I know from personal experience in some states where there's a lot of poorly insured or uninsured people, there isn't often help for following up what happens. Those people are on the hook for the monetary costs of getting that biopsy. And, which is really problematic because it does lead to a lot of women, getting a positive screen and not getting followed up or failing to show up for screening at all. Because what's the point of getting screened if you know if something's found, you're not going to be able to afford to have it checked out. So I think it is a critical thing to look at, but it's tough because a lot of them will just sort of disappear from the database. The other thing I was wondering about is uh, I've gone back and forth to Canada a lot, and I know for a time, and I don't know what's happened since then, for a time, the Canadian guidelines were much, when in the US, people were getting screened every year. In Canada, it was biennial. And, I don't know if it's continued to be sort of that they have a less aggressive um, policy towards how often people should get screened. And I don't know if that would have an influence, in Vermont, where maybe people are a little more aware of what our neighbors to the north are doing.
That's really interesting. Yeah, that's a good point. Yeah, and I think on the cost question too, it's something that we could look at um, with the VCURES data. There have been a lot of studies that kind of ask people about delaying care, foregoing care because of cost. So we don't have that kind of self-report, how people, because I think there could be a difference between what costs look like on paper and how people report it impacting them. But we can at least look at, is this somebody who had a high burden of out-of-pocket costs in the previous 12 months and then they get an abnormal mammogram and it's just too much.
It was a great talk and great work, by the way.
Thanks.
Well, it seems like the U.S. Preventive Services Task Force has bounced around a lot over the decades on women aged 40 to 49. If I'm remembering correctly, maybe 1990s or late 80s, they judged insufficient evidence for that age
I
group.
think that might be right. That's what I went back as far as 2002 for my figures and
Yeah, and
then
I'm remembering like
got really weedy.
some controversy in the literature
Yeah.
earlier than that because they didn't come up with their only recommendation was insufficient evidence. Do you have an opinion on that age group?
Um, well, this is something that Brian can explain better than almost anybody because the Vermont Mammography Registry is part of the consortium that provides the evidence to the U.S. Preventive
Okay.
Services Task Force. So um, it made a lot more sense when I sort of heard it explained by him with the change to what I think is the tomosynthesis. Is that right? That where kind of the evidence that was emerging in 2009 was um, that not only, I mean, we've always known that rates of cancer increase with age, so the women in their 40s are least likely to have cancer detected because they're least likely to have breast cancer. So they're kind of least likely to benefit from the screening. And then I think what that evidence synthesis at the time was showing was they're also more likely than other age groups to experience the false positives. And then with the false positive rates going down with the newer screening technologies in 2024, I think it makes sense, but I think it's so confusing for people that it just kind of feels like it feels like they can't make up their mind when there really is a good rationale for that. And I feel like the messaging is not great around really, the U.S. Preventive Services is task force is very good at the technical work that they do, but I'm not sure if they're that good at the messaging work.
That's a good point. And yeah, sometimes recommendations change because the evidence changes. So,
Yeah.
I have
Oh,
a question about, first of all, thank you, Sarah. This was great. Are you guys are there plans to communicate your results and findings out to the communities? I mean, I think this is great news for the PCPs to reinforce the great work they're doing, right? That they've got the highest rates and would be a really positive message to send out to our communities. Just wondering how you're planning to share this information out to the general public.
I mean, I will say we have excellent communication folks in the Cancer Center, and when we published that Burfus paper with the national results with Vermont as the kind of extreme, um, we were able to do a lot of local media with that work. So I'm hoping we're in revisions now, pretty easy revisions. So knock on wood, hopefully we'll get this published, or at least accepted not too long from now. So it would be great to be able to reach out through some of those mechanisms again.
Good.
looks like time for the one last question, which Tiffany is asking about the laws about reporting breast density and if that has had an impact.
That's a good question. I know that this is also an area that Brian is doing a lot of work in because, as I understand it right now, there's like a notification law, but there's no guidance about what to do with that notification. And I know that a lot of his work is trying to inform actual, with actual evidence, what modes of screening would be appropriate or how to use breast density in addition to other measures of risk to determine what kinds of screening approaches are appropriate for that population. But right now, there isn't really good guidance, so it's really hard, I think, to tell. I'm not sure if there have been any studies that kind of look in across different states and look at states with and without those notification laws and look at trends. That I'm not sure.
That'll give you something to do, something
Yeah,
else to do.
yeah,
Thanks, Sarah, and thanks
yeah.
everybody for
Thanks so much.
joining and participating. See
Thank
you
you.
April 17th.
Yep.